So in June 2019, we were reminded through our regular Quality Network newsletter about a report that had been published by the CQC in that month. It was critical of the way that providers are using the Mental Health Act Code of Practice, which was revised in 2015. They think it's not being used as it was intended to be, with variation in providers' understanding of the code and how it should be applied. I'm going to use this presentation to take a very brief look at that report, Mental Health Act Code of Practice 2015, an evaluation of how the code is being used. In it, the CQC said they intended to look at 3 key areas to gain insight into the issues they were exploring. Those areas included the understanding and application of the guiding principles, engagement and involvement of patients, and Section 140 of the Mental Health Act. Just to remind you, Section 140 is the duty on commissioners to notify local authorities in their areas of arrangements for admitting people in need of urgent care and having sufficient facilities for children and young people under the age of 18. In this quick presentation, I only want to look at the guiding principles. So the report states that providers lack the understanding about how to promote, apply and report on the guiding principles in the Code of Practice. They also found that providers did not support staff wide enough to enable them to have meaningful and productive conversations with patients. They identify that independent mental health advocates provide extra safeguards, but said a review of Mental Health Act reports showed ongoing difficulties with providing IMHA support. The report also makes some interesting points. After discussion with stakeholders, they think that the awareness of the Code of Practice and its easy read version remains low among patients, families and carers. Even when they knew about the code, they found it difficult to navigate or use it in a meaningful way. It points out that over the years the code has grown from 135 pages to over 450 pages. The CQC also discovered that the quality, content and focus of training for staff on the Code of Practice varied. They saw some good examples of practice, but they feel that the size and breadth of the code was a real challenge and some providers hadn't updated their training to reflect the 2015 amended code. I think this report and its emphasis on the Code of Practice may be a reflection of the fact that people are increasingly thinking that the Mental Health Act itself is in urgent need of review. On the Mind website, they quote Suzanne Hudson, chair of the Mental Health Alliance, and she said, "The revised Code of Practice includes greater involvement of patients and better safeguarding of patients' rights. However, guidance can only go as far as the legislation allows, and the Act itself is outdated, discriminatory, and requires significant review." With this in mind, and the reason for this presentation, I think this is a critical aspect of our business to improve on and get right. So the guiding principles are: 1. Least restrictive option and maximising independence. 2. Empowerment and involvement. 3. Respect and dignity. 4. Purpose and effectiveness. 5. Efficiency and equity. I guess the least restrictive alternative is always going to be to not come into hospital, but that's not how the situation is all the time. Some people are required to remain in hospital on a Mental Health Act section, but even in those situations we still need to think about the least restrictive option. There are plenty of decisions that we make and lots of things that we do for people where we further restrict their liberty as well as other aspects of their daily lives in a secure service, or if detained people aren't free to come and go as they wish. When they're on our wards, we have to introduce organisation and rules so they run smoothly and efficiently. We need to be careful with each rule that we introduce so that we ensure that we help people retain their respect and dignity. Respect and dignity starts with treating the person as an individual, with talking to them and trying to understand their needs and how their illness affects them and impacts their lives. I know that we already do plenty of things that help to maintain a person's respect and dignity. What I think we need to do now is to find ways to relate the things we do with the Code of Practice's guiding principles, as well as other requirements as they relate to our work. The Code of Practice further defines the respect principle by stating people taking decisions under the Act must recognise and respect the diverse needs, values and circumstances of each patient, including their age, disability, gender reassignment, marriage and civil partnership, pregnancy and maternity, race, religion or belief, sex and sexual orientation and culture. There must be no unlawful discrimination. That's a huge and complex list, and we could take a whole morning to think it all through. However, what I can say with a degree of confidence is that we will ensure we have the best chance of abiding by this principle by talking about it. Talking about these things with each other, with our service users, their families and carers and so on. The purpose and effectiveness principle, the fourth of the guiding principles, is about the treatment and care that we provide our service users. It means that we have to know why we do things and why the things that we do will help address the problems that people are with us to help resolve. The other thing that's very relevant for low and medium secure services, as well of course for other acute services in the Trust, is that the Code of Practice says that care plans for detained patients should focus on maximising recovery and ending detention as soon as possible. We are rightly challenged in lots of ways to ensure that when we don't discharge a detained patient, that we have a clear understanding and a good rationale for continuing detention, and that has to be based on safety and treatment and capacity. The issue of detention also comes up in the efficiency and equity principle. In relation to this, we're told that where patients are subject to compulsory detention, health and social care agencies should work together to deliver a programme of care. As far as practical, working together, we should minimise the duration of detention, facilitate safe discharge from hospital, and take into account the patient's wishes. We are told that we should have good working relationships with commissioners, providers and other relevant organisations. Our staff should have sufficient skill, information and knowledge about the Act and provision of services to support the people that use our services. Now, I'd only ever intended to do a quick 10-minute presentation just to introduce these ideas to you. I think that it needs picking up by the teams. I also think there are things that we can do locally as well. We can use these guiding principles whenever we develop a local policy or protocol that impacts on the way that we interact with service users. We could very easily declare our commitment to the Code of Practice as often as we declare our commitment to best practice. So that would be newsletters, job adverts, peak of the week, wherever we're promoting our services or the Trust. We generally like to say that we're committed to best practice, evidence-based practice or client-centred practice. But we could also state authentically that we focus on the Code of Practice. If you think about the guiding principles as, say, you write a report and make reference to them, then every time that gets read, you're prompting a colleague to think about the Code of Practice. The more that happens, we'll start to generate wider discussion about the guiding principles and demonstrate how their relevance impacts on our practice.